Good evening, everybody, and welcome to ICON's Facebook Live session on bladder cancer. For those of you who haven't watched these sessions before, Dr. Ian Irving is my name, and I have the privilege of being ICON Group's Medical Director. I practice as a clinical haematologist at ICON Wesley and ICON Mackay, and also sit as a director on the ICON Group board. Tonight, we've got a great session. We're going to have the first half of the session in a format that's very much a question and answer with two of our ICON doctors. One, Dr. Renee Finnigan, a radiation oncologist. Renee is a radiation oncologist at Gold Coast University Hospital with ICON Group. She has a particular interest in brain, head and neck, breast, prostate, and urogenital cancers such as bladder cancer. Renee is also an ambassador for the Beat Bladder Cancer Australia Scientific Committee, and we're really blessed with having Renee with us tonight. So thank you for joining us, Renee.
Hi, Ian. Hi, everyone.
We also have medical oncologist Dr. Mohammed Islam. Mohammed is a medical oncologist at ICON Southport, as well as the Gold Coast University Hospital. Has a wide range of interests within medical oncology, including gastrointestinal tumours, urogenital malignancies such as bladder cancer, lung cancer, as well as head and neck cancer. So welcome, Mohammed, and once again, thank you for joining us for tonight's session.
Hi, good evening. Thanks for having me.
Yeah. ICON Cancer Centre has over 35 treatment centres around Australia. I know we'll be reaching patients, relatives, interested friends and parties throughout the country, and we very much value your questions regarding bladder cancer tonight. So please, through the appropriate channel on the Facebook Live website, please ask your questions of our two experts. Anything you want to ask regarding bladder cancer is fine. The only thing, of course, I would caution everybody about with questions is just be careful with personal information and please, don't disclose too much of your own personal medical details for discussion on the session, but certainly any question of a general nature about bladder cancer, we will put through to our two experts tonight. As I discussed at the start of the session, the first 30 to 40 minutes is going to be questions that I will put to Renee and to Mohammed regarding bladder cancer, and we'll go back and forth like that for over the first half of the session, and then we will get to your questions that you've put through the Facebook Live website, including some of the questions that you've put through ahead of time. So I think it's probably a good time to start. It's enough introduction from me, and we'll go to Renee first. May is Bladder Cancer Awareness Month, so we're midway through May, and the whole month, the great cancer groups that deal with bladder cancer are out educating the community about bladder cancer. But Renee, could you tell us who gets bladder cancer? What are the risk factors, and how does one avoid getting bladder cancer?
So around 3,000 Australians are diagnosed with bladder cancer per year. It's most common in people who are over 60 years of age, and men are 3 to 4 times more likely to be affected than women. Some of the risk factors for bladder cancer are smoking, and some workplace exposures to certain types of chemicals and dyes. But anybody who has typical symptoms should be investigated. Some of the ways that people can try to avoid bladder cancer are to try to have it picked up early. And that would include going to their GP if they get any suspicious symptoms, things like hematuria, which means blood in the urine. And that hematuria might be microscopic, which can't actually be seen to the naked eye, but picked up by a GP on a urine dipstick, or detected if a urine sample is sent to the laboratory. Or it can be macroscopic hematuria, which is where the urine is visibly blood-stained, usually pink or orange, or less commonly dark red. And this hematuria from bladder cancer is usually painless, but people may experience some other symptoms similar to having a urinary tract infection, so discomfort or burning sensations when they pass urine, or a change in their urinary habit, like needing to go to the toilet more often, more urgently, or more times at night. Less common symptoms would be things like lower abdominal pain, or back pain, or more advanced disease may present with things like fatigue, unintentional weight loss, nausea. But it's important to remember that all of those symptoms can be caused by other things, and often the other things are more common. So things like urinary tract infections or prostate disease or kidney problems can present in the same way. So the first step is usually to go to the GP to get it checked out.
Sure. No, thank you. So certainly if you have blood in your urine that you're calling hematuria, if you ever notice blood in the urine, that's not a normal situation and needs investigation. Is that correct, to paraphrase you that way, Renee?
Absolutely. Yeah.
Right. Now, you mentioned there about men suffering bladder cancer more commonly than women, and one of our Facebook Live registrants has actually put that through as a pre-poll question as to why do men suffer bladder cancer more often than women? Is it known?
Look, it's a good question, and the truth is that we don't completely understand why. Historically, it was thought that because more men than women smoke, or more men than women work in some of those industries that have the chemical exposures that make bladder cancer more common. But we now know that that's not the complete answer. Even amongst non-smokers, bladder cancer is more common in men than women. And there's actually been some animal studies that have intentionally exposed animals to some of those dyes and chemicals to give the animals bladder cancer. And even in those trials, the male animals get bladder cancer more than the female animals. So there may be some hormonal reasons that we don't yet fully understand.
Okay. No, thank you, Renee. It's another one of those mysteries as to women being stronger than men, but for an unknown reason.
But even women who have the bleeding should go and get it investigated, even though it's more common in men. It still happens in women, and it still happens in young people too.
Okay. Before going over to Mohammed to talk about the investigation and treatment, is bladder cancer common? Renee, you mentioned 3,000 people. I mean, putting that in context, is this one of the commonest cancers in Australia, or is it rare? Is it increasing in frequency, or bladder cancer?
So it's not one of them. It's not a common cancer, but because it can be quite a serious cancer, if not detected and treated at its early stage, it still has quite a big impact on the health of Australians, and particularly the health of men. Hopefully, with fewer and fewer Australians choosing to smoke or being more successful in quitting smoking, hopefully that incidence will go down. But at this point in time, it's not yet going down.
Yes, okay. I mean, it's always a good message to give people to certainly stop smoking, and even if you have smoked for a number of years on smoking cessation, there are a multitude of health benefits, both the reduced cardiovascular risk of cardiovascular disease and reduced risk of cancer. So we always like to emphasize that to our audience, that it's never too late to stop smoking. So that's a good reminder, Renee. Mohammed, bladder cancer, going back to our topic at hand tonight, can you, if you do have blood in the urine, you go to the GP, how is bladder cancer likely to be investigated and a diagnosis made?
That's a very good question. Now, as Renee said, the earliest sign or the prime sign and symptom of bladder cancer is a painless bleeding with the urine. We call it painless hematuria. So there's no pain, but the blood in the urine. The blood could be just a dark colored urine, a cloudy or smoky colored urine, a pink colored urine. So these are and that where the patient should go to GP and get the urine tested. Other symptom could be just the urinary tract infection like symptom. Regardless of the symptom is, particularly if there is any urine color change, patient should go to the GP. And the GP initially will test the urine as a standard urine test, like we call it routine microscopic midstream urine test. And also, if there is any hematuria, GP probably will do the cytology. That is, he will ask to test whether any abnormal cell in the urine. So he will test abnormal cell in the urine. At the same time, he will check whether there is any bacteria or virus, anything, any pathogen in the urine. So if there is an infection, he will treat in that way. And if there is any abnormal cell, then he will refer the patient to the urologist for further investigation. Most of the time, urologist will be doing cystoscopy. Cystoscopy is the camera put through the urethra to the bladder and look at the bladder, inside of the bladder, to find out there is any abnormal collection of the cell or abnormality there. And if there is, he can take some tissue and test it under microscope to find out whether there is a cancer or not. Other investigation like ultrasound scan of the bladder, that can also show whether there is any abnormal growth or anything inside the bladder. And CT scan also that can show whether there is an abnormal growth, and also whether there is any abnormal lymph node around the bladder that can be detected as well.
Right. No, thank you. So there are various tests that can be done. Assuming then someone has a cystoscopy and a biopsy and a diagnosis of bladder cancer is made, are there different types of bladder cancer? How is bladder cancer after a biopsy characterized? Is there early and late stage disease or different types? How would you explain that in a way our audience would understand, Mohammed?
Yeah, now that's very important message we can give to the audience. It's important to know that, I mean, at the moment, let's forget about the histological variant. Let's see about the presence of the cancer in the bladder, and we can divide the bladder cancer depending on the invasion of the cancer to the bladder well in two types. One is superficial type, which is just the bladder wall, and another type is when the cancer goes up to the muscular layer of the bladder. So if it is just a superficial layer or up just over the wall of the bladder, that is not an extensive stage cancer. Most of the time, the urologist or the surgeon, they can take that cancer out. We call it transurethral resection of the bladder tumor. I mean, I don't know whether any of our audience, if they ever had bladder cancer, and they would know the term TURB. So that's a transurethral. It's not a major surgery. They don't need to open the tummy. They just go the way they did cystoscopy, same way they go to the bladder and take the tumor out. And that is, again, they take the tumor out and the tumor can be tested, how far it was, what type of cancer it was. If it is superficial, then after the, sometimes they don't need to do anything, just the follow-up. Sometimes they do intravesical BCG. The BCG, if you remember, we use for tuberculosis vaccine. That BCG, They use it through the catheter to the bladder and to stop the cancer from coming back. Sometimes they do intravesical chemotherapy as well. That is also to stop the cancer from coming back. So that is if it is superficial. But if it is deep, in that...
Just before we go on to the deep cancers, so the superficial cancer, a superficial bladder cancer is when the tumor, when the cancer cells have not gone through the muscle layer of the bladder.
Exactly.
That's right. Excellent. No, thank you. So when it is superficial like that, Mohammed, and it hasn't gone through the muscle layer, then you're saying the treatment is either a surgical resection of the bladder cancer, or in some cases, a surgical resection followed by some chemicals, such as either the BCG vaccine or some chemotherapy, being infused into the bladder.
Correct.
Right.
That's right. But there are some trials when happening. That's not the standard of care yet, but they are investigating whether after in this situation, the bladder cancer is superficial but looks aggressive, whether there is any systemic chemotherapy or immunotherapy of any benefit. So we will know that answer probably next year.
Okay. This trial of giving chemotherapy to early stage bladder cancer, are those trials being done in Australia, or?
I think so. Yeah. We don't have in our center, but it is in Australia.
Right, but it is. Okay, the final point just to make about the superficial cancer before we might throw back to Renee for management of the deep cancers. When you infuse the BCG vaccine that you told us is normally given as a vaccination to prevent tuberculosis, how does that help treat bladder cancer and to stop a superficial bladder cancer from returning?
That is an interesting question. This BCG vaccine just works like an immunotherapy. I don't know how our audience, I think immunotherapy is the talk of the century. This is the game changer in the world of oncology. It boosts your own immunity to kill the cancer cell. We call it cytotoxic T cell. So the BCG vaccine works in that way.
Right. Okay. No, fascinating. Well, let's go back to Renee then. I mean, it seems, of course, that we always say that the best treatment, of course, for any sort of cancer is prevention, and it's best not to be diagnosed with cancer. Of course, superficial or early stage bladder cancer is preferable to later stage disease, but of course for all of us, we don't get to choose our illness or our stage of illness. If someone has bladder cancer that has gone through the muscle layer in the bladder, Renee, how is that cancer treated?
So bladder cancers which have invaded into the muscle but haven't spread beyond the bladder are most commonly treated with surgery, with surgical removal of the bladder, as well as the lymph nodes that are around the bladder. And it's a procedure that's done by urologists called a radical cystectomy. Urologists are surgeons who deal with bladder cancers and other types of genital urinary cancers. For men, a radical cystectomy usually also removes some of the other structures that are very close to the bladder. So it often includes the prostate gland and the seminal vesicles. And these are glands that sit just underneath the bladder, which are important for sexual function. And they also remove part of the urethra, which is the tube that carries urine from the bladder to the outside of the body. For women, a radical cystectomy also removes the bladder and the lymph nodes, but often usually the ovaries, the uterus, the cervix, the upper vagina and part of the urethra are removed as well. When you're removing the bladder surgically, you then need to have a different way for the urine to drain from the kidneys, so they need a different route. And there's a few options for how the surgeon can reconstruct this half of the urine. They all involve removing a small section of the bowel, which they do during the same operation. And then that part of the bowel's reattached, and the part of the bowel that they've removed is cleaned and prepared and then connected to the ureters, which are the little tubes that connect, that drain the urine from the kidneys. And then there's two ways to reconstruct the pathway. The most common is what's called an ileal conduit, and that's when they bring that section of the bowel out to the surface of the abdomen, and it's usually on the right side of the abdomen, and that's called a stoma. And people can attach a bag over that opening, and the urine will collect in the bag, and then the people can just periodically drain the bag and get rid of the urine that way. Some patients are able to have a new bladder created from the section of bowel that's been removed, and that's called a neobladder. And that's then reconnected to the person's urethra to get the urine out of the body, and the person's able to urinate more normally. The best type of urinary diversion depends on patient preference and the surgeon's expertise, but as well as the extent of the cancer. And it's something that patients would usually have quite a detailed discussion with their urologist, with their surgeon, before having an operation.
Sure. Are there any alternatives to surgery? I mean, if you have an invasive bladder cancer, and we'll throw back to Mohammed in a minute to talk about chemotherapy and the role of potentially chemotherapy before surgery. But instead of having that sort of operation that you described, which of course is major surgery, is there any other way to have chemotherapy and then other treatments instead of surgery, Renee?
Yep. So an alternative to surgery for some people is radiation therapy. And radiation therapy can be used to cure bladder cancer. It's often delivered in combination with chemotherapy or other non-chemotherapy drugs that make the cancer more sensitive to radiation treatment. And we call this combined bladder preserving therapy. There are different types of radiation therapy, but the radiation for people with bladder cancer is usually external beam radiation therapy, which is using high energy X-rays that are targeted from outside the body and all focused in on where the cancer cells are. And modern radiation therapy is very carefully planned and delivered to make this safe. The radiation therapy works by destroying or inactivating the cancer cells in the targeted area, and it does that by damaging the cancer cells' DNA. There can be some damage to the normal cells as well, and that's why there's some possible side effects. But the normal cells are better at repairing themselves than the cancer cells are. This type of treatment, the radiation, is suitable for people who are not fit for surgery because of their other health issues. But it's also an option for patients who are fit but who want to try to keep their bladder. There hasn't ever been any trials directly comparing the two options, surgery versus the bladder preservation therapy, but the overall survival rates that have been reported are quite similar. And the best patients for this bladder preservation treatment are those who have a muscle invasive bladder cancer, but one that's not too extensive, and those people who have a bladder that's functioning well before the treatment starts. Because if someone already has a lot of bladder symptoms before the treatment even begins, they may actually have better quality of life from surgery.
Cool.
And if they do have radiation, we still ask them to attend for regular follow-up with regular cystoscopies afterwards to make sure it's gone away. And some people, if it does come back, could still have an operation down the track.
What sort of side effects can you suffer from radiation therapy to treat bladder cancer, Renee?
So side effects from radiation therapy vary from person to person. We usually divide them into two types, either short-term side effects or long-term side effects. Short-term side effects are those that happen during the treatment. They're usually worse towards the end of radiation treatment, and they may peak 1 or 2 weeks after the treatment finishes. And then they usually improve within 6 to 8 weeks after the treatment finishes. And those common short-term side effects during the radiation are feeling tired, and having irritation of the bladder. So it can feel like a urinary tract infection where people need to pass urine more urgently or more frequently, get up more times at night to pass urine, sometimes have some stinging or discomfort when they pass urine, and occasionally some loose bowel motions or discomfort in their tummies. These usually resolve by 3 months after treatment, but some patients do experience some persistent side effects or some side effects that can happen months or years down the track, and these are called the long-term or late side effects of radiation treatment. They're less common, but they may be permanent, and those potential long-term side effects, again, are changes to the bladder or the bowel habit, so needing to go to the toilet more often or more urgently. Sometimes people get some bleeding from the back passage or some swelling of the legs, and there can be some effects on sexual function and fertility. It's
very helpful.
There's some uncommon side effects like having leaking of the urine or a bladder that really can't hold enough that bladder that really can't hold enough urine to be useful. But these are much less common, and of people who've had radiation therapy for their bladder cancer, 5 years down the track, 80% of survivors have a functional cancer-free bladder.
No, thank you. That's very comprehensive, Renee. Thank you, and sorry for diving in a little bit early there. I mean, Renee's gone over that, for more advanced bladder cancer where it's penetrated the muscle, chemotherapy plus radiation therapy is an option. Also, there is the option of chemotherapy followed by surgery, which is perhaps the most common and more traditional way of trying to cure bladder cancer that has penetrated through the muscle layer. Renee, thank you for being so thorough and comprehensive in your answer there. Can I go over to you, Mohammed, for both the two options that Renee went through, the traditional surgical approach, and it's quite amazing what a modern day surgeon can do, really, how some of these operations that really would not have been thought possible decades ago. But either if surgery is going to be performed or radiation therapy as an alternative to surgery, can you go through the chemotherapy and the role of chemotherapy that is often combined with either of the two approaches, either surgery or radiation, for us, please?
Yep. As Renee said, the standard of care for muscle invasive bladder cancer is surgery. That is the standard of care. So in any case, if the patient is not operable because of other medical comorbidities, those patient goes for radiotherapy and chemotherapy in combination. So I talk about the standard of care first, which is if the patient has muscle invasive bladder cancer, we give them some chemotherapy. After the chemotherapy, there is a 4 to 6 cycle of chemotherapy named gemcitabine and cisplatin. After finishing chemotherapy, the patient we give them a recovery time of 3 to 4 weeks, sometimes a bit longer, and then they get surgery by the surgeons. Most of the time they get cystectomy, that the whole bladder is taken out. Renee has covered that portion, so I'm not going to in detail that. If the patient gets chemotherapy before the surgery, the data or the trial shows is about 7 to 8% extra survival benefit, that the patient lives longer and it reduces the risk of cancer coming back. In any case, if the patient did not get chemotherapy before the surgery and went to the surgery straight away, then still there's an option of having chemotherapy after the surgery. We call it adjuvant chemotherapy. Again, that is not the standard of care. Standard of care is chemotherapy before the surgery. But it can be given after the surgery, but benefit is not as good as before the surgery. Now, coming to the combination of chemoradiotherapy for the patient who are not eligible for surgery. One of the reason not eligible for the surgery is different comorbidity, and in that comorbidity, it could be significant renal impairment. In that case, chemotherapy could be really challenging, and then we call our radiation colleagues to give them just radiotherapy, because the chemotherapy would kill the patient because of a very poor renal function. If the patient renal function is, at least not too bad, in that case, we give some chemotherapy. There are different type of chemotherapy we can use. Most commonly, we can use two chemotherapy together. It's called carboplatin and paclitaxel. Sometimes, if the patient is robust, we sometimes give a bit of cisplatin as well. But most of the time, we that can be given. Sometimes we can give gemcitabine and cisplatin as well, but the most of the time we use carboplatin and paclitaxel.
Okay. You mentioned there, Mohammed, that patients whose kidneys aren't functioning too well, it's much more difficult to give chemotherapy, and you can have side effects, even very serious ones. What sort of side effects do patients usually see when given this chemotherapy, such as cisplatin and gemcitabine, or some of the other drugs, carboplatin, that we give for bladder cancer? What are the common side effects you'd like to educate people about?
Right. There's a myth of chemotherapy is the chemotherapy can kill patient, but that's not true anymore, because we can manage the side effect very efficiently nowadays. So I'll tell many things, but those are the intensity of the side effects are not that bad anymore. Again, the side effects varies from patient to patient. Some patients encounter lots of side effects, and some patients, they go through the chemotherapy like lolly water. They don't get side effect at all. But in general, chemotherapy, they can get nausea and vomiting. Our patient doesn't really vomit anymore, because we give very good medication to control the vomiting. So they can get a bit nausea there. So tiredness, lethargy can happen. The hair toxicity is common with the chemotherapy, so they can have thinning of the hair. Then few other side effects like mouth ulcers, skin rashes, diarrhea, or constipation. But the most significant and most important side effect we need to remember, the chemotherapy can drop the immunity. So the patient can catch infection very quickly. And that is the side effect. We have to be very vigilant and watchful. So during the chemotherapy, if the patient gets fever, that means he caught up with infection. We need to remember the low immunity and infection is not a very good combination. Patient can even die from it. So fever means come to hospital so that we can treat efficiently.
Right. That's such an important message, isn't it, with all types of chemotherapy? Although some things have come a very long way in the last 10, 20, 30 years. And as you say, Mohammed, side effects such as vomiting are quite rare now, and there are some wonderful medications that can stop chemotherapy-associated nausea and vomiting. But as you point out and emphasize, infection after chemotherapy is still a concern for all of us who work in oncology and hematology. And as you have said, if you have any temperature or fever or any other sign of infection after chemotherapy, you must present to hospital, to medical attention as soon as possible. We've had a question through the Facebook Live channel going back to radiation, and that is, when radiation therapy is given for bladder cancer instead of surgery, Renee, how many treatments or how many fractions are normally required?
Yeah. So radiation treatment is generally given as an outpatient procedure, and it's given as a course of treatments, usually with daily treatments Monday to Friday with a break on weekends. And for curative bladder cancer treatment, the whole course would usually go from 4 to 6 weeks. So between 20 and 30 sessions with 5 sessions per week. Each of the treatments takes about 10 to 15 minutes. And much of the time is actually spent getting patients into the right position and making sure that they're comfortable. The treatment itself only takes a few minutes. We just ask patients to lie nice and still. The machine moves around them and makes some clicking noises, but they don't see or feel the radiation while it's happening, just like when someone has an X-ray or a CT scan. And after its sessions finish, there's no radiation left in the body. Patients are free to be around other people. Patients often drive themselves to and from treatment, and some patients would actually still continue to work during treatment.
Right. Now, Renee, you mentioned that patients receive radiation therapy for 5 days each week. I mean, we know there are 7 days in the week. Why is it that radiation therapy is delivered Monday to Friday and not 7 days a week with Saturday, Sunday treatments?
So trials have been done for various types of cancer where patients have actually been treated without a break 7 days a week. And we find that the short-term side effects are actually much worse if patients don't have any breaks during treatment. Having said that, having too many breaks in treatment can also reduce the effectiveness of the treatment and lead to poorer tumour control outcomes. So it's a little bit of a balance between wanting people to have their overall treatment time not too long, but with giving them enough breaks so that they can actually get through the treatment without too many side effects.
Right. No, excellent. No, thank you for that. So it's certainly not compromising people to have those 2 days break. In fact, it's important. It's a bit like your working life. It's important to have some downtime and have the weekend off so you can refresh your mind and body for Monday morning. So, no, thank you for sharing that research with us.
And also just to say that for that 4 to 6 weeks of treatment, that's if somebody is having the radiation treatment to try to cure the bladder cancer. We also use radiation treatment for patients who have very advanced disease or disease that's spread to other parts of the body. And in that case, we're not trying to cure the cancer, but we're trying to shrink it or improve symptoms. And those courses of radiation treatment are often much shorter. They might be a single treatment or just 1 to 2 weeks of treatment. And they also tend to have far fewer side effects.
No, thank you. That's a fantastic segue, Renee, because you've read my mind. I was going to go over to Mohammed to ask about the treatment of bladder cancer when it has spread away from the bladder to other organs. So again, it's an unfortunate reality of cancer therapy that cancer is not always diagnosed early, or even if it is picked up and treated relatively early, it can recur and can become metastatic, or i.e. have spread to other parts of the body. So Mohammed, would you be able to take us all through what is the best treatment for treating bladder cancer that has become metastatic, i.e. it has come back and spread to other organs?
Yeah, when the bladder cancer is outside of the bladder, we call it metastatic disease. Unfortunately, that is not a curable disease anymore. So we control the disease and improve the symptoms. Now, as Renee said, if the patient has a specific problem like pain or significant hematuria or bleeding, in that case, our radiation colleagues can give few fraction of radiotherapy to control the pain or the bleeding. Sorry. So the metastasis could be anywhere. It could be lymph node, it could be in the bone or other organ. So that is the radiation part for the symptom control. And for the systemic treatment is mainly chemotherapy. We give chemotherapy, and generally we give 4 to 6 cycles of chemotherapy. During the chemotherapy, we do scan, commonly CT scan, to see the treatment response. What is treatment response? It could be 3 outcomes. Number 1, the tumor is shrinking. That is the best outcome. Number two, it hasn't shrunk that much, but it is stable and did not get any bigger, and there is no new spots or new cancer. That is the number two. We also accept it as a a chemo response. And third one, which we do not expect, and unfortunate, is in spite of chemo, cancer still growing. So that could be three outcomes. If there is first two, then we continue chemo up to 4 to 6 cycle. Depends on the tolerability of the patient. Like if too many side effects, we stop a bit early. And if there's not many side effects and good treatment response, we can go up to 6 treatment. Now, after the initial chemotherapy, we can use maintenance immunotherapy. And immunotherapy can improve the survival and the control of the cancer much, much better than the chemotherapy itself. So that's the blessings. As I said initially, the immunotherapy is the game changer. It improves the survival and also improves the progression-free survival. That is, it controls the cancer coming back as well. Thank you.
Excellent. So tell us then, Mohammed, how does immunotherapy work in bladder cancer? What does it do? We hear a lot about it, and that's great that it is a potential game changer in the treatment of metastatic bladder cancer. But how does immunotherapy actually have an effect?
Right. Yeah, that's interesting, really. It is your own body immunity. It is nothing foreign to the, like chemotherapy. Chemotherapy, it is a direct combat in the war. Like it goes and kills the cancer cell. It's called cytotoxic stuff. But the immunotherapy, what it is inject, it will boost up your own immunity. I explain it in a bit different way. Like if you get a foreign body in the body, like virus or bacteria or whatever it is, your own immune cell specific to that virus, bacteria get activated. If they get activated, it kills that cancer cell, the virus or bacteria, and then immediately after that, it deactivated. It becomes inactive. The the immunotherapy, what its role is, keep that immune cell or T cell active all the time. So it doesn't get inactivated at all. So when body detect the cancer cell, the immune cell go and kills it. And normally, immediately after killing the cancer cell, it gets inactivated. But the immunotherapy, it keeps it activated all the time. So it keeps killing the cancer cell. So this is interesting.
Yeah.
So that's the way it works. It's the body's own immune system.
Right. So the immunotherapy drugs, and we're talking drugs like Keytruda, pembrolizumab, they act on stimulating the person's own immune system so that the person's own cells then go to kill the cancer cells.
Correct.
Right.
Yes.
Sure. Fascinating. Now, with immunotherapy for bladder cancer, does someone lose their hair if they're being treated with immunotherapy?
So immunotherapy, normally, it is not a chemotherapy. So it doesn't cause side effect like chemotherapy, but rarely, but surely, it can give some side effect as well. Side effects are also, we call it autoimmune toxicity. Like body's immune system, when they are hyperactive or overactive, they can cause some problem. Like we have autoimmune disease, isn't it? Like diabetes, rheumatoid arthritis, these are autoimmune diseases. The immunotherapy, it causes some problem as well. Not like that fall of hair, but it can cause bad skin rash. It can cause bad diarrhea. It can affect the thyroid gland, the gland sitting here, and which controls the metabolism of the body. So it can make thyroid gland overactive or hypo or low active. It can infiltrate the lung and cause some lung problem. It can also affect the kidney and liver. It can affect a gland at the top of the head called pituitary gland and cause some hormonal problem in the body. It can cause unexplained neurological problem, unexplained fever. So all those, only the side effect is only 10 to 15% altogether, and the lung and then pituitary gland, these are 1 or 2% possibility. So I would say the immunotherapy, if 85% chance, the no side effect, but the 15% chance there could be side effect. But the most of the time, we can manage the side effect by holding the immunotherapy or giving some steroid tablet, and then can restart the immunotherapy again. But 1 or 2 or 3% cases, the toxicity could be too tough to control, and then we may need to permanently discontinue the immunotherapy.
Sure. No, thank you. It's a fascinating branch of oncology, the immunotherapy, and I think that's excellent the way you've explained it, and how 85% of people have no side effects, but the 15% who do have side effects, it can be all sorts of things can occur. Just going back to Renee, can immunotherapy be combined with radiation therapy? Is that a treatment that can be used for bladder cancer at all?
So it's certainly an area that's being investigated at the moment across a whole lot of different cancer types, and it's something that people are very excited about. I'm aware of, that we don't have data about using immunotherapy at the same time as radiation treatment for bladder cancer at the moment, but I'm sure that it's a topic that, if not being investigated already, will be in the near future.
Okay, and we had a question from Maria regarding radiation therapy that came in, Renee, and Maria asks, if you have radiation therapy for bladder cancer, can you have radiation again, or is radiation therapy a once only treatment?
So there is a limit to how much radiation each body site can safely receive. So for patients who've been treated with curative intent radiation therapy to the bladder, we would usually try to avoid giving further high dose radiation to the same area. However, we can definitely treat other sites in the body, or we could treat with low-dose palliative radiation therapy if there's been a reasonable interval between their high-dose treatment and then needing some more low-dose treatment down the track. But generally, we would try to avoid treating the same site with 2 courses of high-dose treatment. There's always exceptions to that rule based on individual circumstances, but that's the general.
Okay, no, that is fine. We've had a few questions come through to do with intravesical chemotherapy. So, Mohammed or Renee, I'll leave this for whichever person wants to take this question. Regarding when is it decided to use intravesical or putting chemotherapy into the bladder, intravesical chemotherapy, such as mitomycin C, when is that used, or when is the BCG given into the bladder instead? How is that decision made?
Happy to take that question. As I said, in BCG vaccine, intravesical BCG is the initial treatment. But if it looks more aggressive or recurrent, like had BCG vaccine a few times and resection of the bladder cancer a few times, then and still not muscle invasive, they use chemotherapy. I mean, as already mentioned, the mitomycin is one of the option and commonest option, really. There are some other chemotherapy can be used as well, but as I mean, yeah. So chemotherapy is a bit of second line for the superficial or initial bladder cancer.
Are they ever used together, Mohammed? Do you give BCG and mitomycin C intravesically together?
Not that I know of. Whether there is any trial or anything, I'm not aware of it.
Sure.
I think I'm not it's usually the domain of urologists and medical oncologists, but I think there may be one trial down in Sydney where they're doing BCG kind of 1 week for 2 weeks, and then intravesical chemotherapy for a 3rd week in those combinations. But I think it is very much the domain of trials at the moment.
Yep.
Right. Okay. No, thank you, Renee. And Mohammed, when you're giving intravesical mitomycin C, so that is chemotherapy, does that have the same side effect risks and concerns as other chemotherapy? I mean, do people lose their hair? Are you worried about infection? Can you get nausea and vomiting? Does it affect fertility?
No. Good question. Our audience should know that intravesical chemotherapy has a very minimal systemic absorption. So the systemic side effect is extremely minimal. I would say next to nothing, no systemic absorption. There could be some bladder irritation and bladder symptom, but systemic side effect is negligible.
Okay, no, thank you. Thank you for that. Just on the side effects, Mohammed, are there any particular side effects for the BCG treatment being given into the bladder?
BCG, again, is intravesical, so systemic absorption is very minimal. But there could be allergic reaction like any immunotherapy or any chemotherapy. And also, sometimes patient gets unexplained fever from the BCG and bladder irritation. So these are the common side effects.
No, thank you. To the audience, once again, thank you for joining in tonight. If you have any questions for either of our two bladder cancer experts, please put your questions through the Facebook Live channel, and we will endeavour to get to your question to ask either Mohammed or Renee. The month of May is Bladder Cancer Awareness Month, and that's why we are doing this special on bladder cancer, often a bit of a forgotten tumour, not potentially the commonest cancer that Australians suffer, but one that we are seeing increasingly frequently as the population ages, given bladder cancer is a disease that's often seen over 60 years of age, more common in men than women, and as we've heard from our experts, can have a radically different treatment, whether it is detected and treated early, that is before it breaks through the muscle layer of the bladder, at which point often surgical resection plus or minus some intravesical BCG is given, versus the situation whereby the tumour has passed through the muscle layer of the bladder, and in that situation either chemotherapy followed by surgery, which has been the traditional approach, or chemotherapy together with radiation therapy is required. So please, any questions, put them through. We'll go to a few more questions now. Renee, what would your message be to our audience? And this has come through for young, from I think a younger member of the audience. What can be done to prevent oneself getting bladder cancer? I mean, you mentioned smoking. What else can one do during their life to help not get bladder cancer?
So, as you mentioned, I think number one, you can't do anything about your gender. So, male or female, that's generally usually set in terms of as a risk factor for cancer. But the number one thing is to try to avoid smoking, or if you do smoke, try to cut down or quit, and often GPs can be very helpful for that. Some of those chemical exposures that we spoke about, I think that from a government level and workplace safety level, a lot of industries are trying to reduce some of those dye and chemical exposures now that we know that they're associated with cancers. Some of the less common causes, like chronic infections in the bladder, I would say, particularly to young people, if you're having lots of urinary tract infections, go and talk to your GP about it. There's lots of things that can be done to try to minimise urinary tract infections. You know, for young, oh, my lights have just gone off. I'm at work too late. For young ladies, there's simple things that can be done, like after having sexual activity, trying to go to the toilet and pass urine shortly after sexual activity, increasing the amount of fluids that you drink, trying to make sure that if you are having recurrent urinary tract infections, you actually do send off a urine sample to make sure that there's nothing else going on or not some unusual infection that's causing it. So really to link in with their GP if they are having any of those urinary symptoms that don't seem to be going away. And if anybody is having blood in the urine, particularly if it's not painful, to go see their GP to get it checked out sooner rather than later.
Excellent. No. Thank you so much for that, and thank you very much for all your contributions tonight, Renee. It's been fantastic to have one of our Beat Bladder Cancer ambassadors and experts who serve on the Beat Bladder Cancer scientific committees here to go through the treatment of bladder cancer. So thank you. As we wrap, thank you. Just before we wrap up, I'm going back to you, Mohammed. Could you maybe tell us about any clinical trials that are occurring in bladder cancer, both within ICON centres or other trials that are being done beyond in other Australian cancer centres? I know that you have a deep interest in clinical trials, and of course we do run many clinical trials through ICON Cancer Centre. But maybe you could, as a way of, plus any other message you want to end on, but just if you would be able to go through some of the trials that are important for bladder cancer.
Yeah. So most important trial we are waiting for the result of it is the immunotherapy as instead of chemotherapy before the bladder cancer. Before the cystectomy or surgery. We call it neoadjuvant immunotherapy for the bladder cancer. That could be game changer as well, because we traditionally using chemotherapy. So if you don't have to use chemotherapy, just immunotherapy before the surgery, that would be great. In that case, I think more than 90% patient will be able to have surgery, and they don't need to have chemo radiotherapy. So that's number one. We're waiting for that. Another trial is chemotherapy and immunotherapy together. That is another trial going on. And even in adjuvant setting, like after the surgery, the role of immunotherapy, the role of it. At the moment in Australia, we cannot use immunotherapy as a first line for stage 4 or metastatic bladder cancer, when the bladder cancer beyond the bladder. We have to use chemotherapy first and then immunotherapy. Many of patients, they're not suitable for chemotherapy. They cannot tolerate chemotherapy. Those patients remains untreated because they can't access immunotherapy. But we know that the immunotherapy probably will help. So there is another trial. We're waiting for the result of the trial. And preliminary, we already know that it is a positive trial, like in stage 4 or metastatic bladder cancer, immunotherapy as a first line works. Then that would be a game changer, or that would be a new standard of treatment in future.
Excellent. Thank you. It's been fantastic. Just like expressed on behalf of all of our people watching tonight, our gratitude to Renee. Thank you also, Mohammed, for coming on and sharing your expertise. You I know, have a wide knowledge across medical oncology in many different tumour types, and of course I've also practiced with compassion and care. If anyone wants to learn more about bladder cancer, we encourage you to go to the Icon Cancer Centre website. We are developing a website that we're putting more and more information on, specifically for patients and also family members and relatives. Again, I thank you all for tuning in tonight. I encourage anyone who either has been diagnosed with cancer themselves or has a relative or friend with cancer to avail yourself with as much information as possible. Certainly the internet has a wealth of information. One does need to be careful about the source of the information on the internet, but I encourage everyone to learn as much about their cancer or the cancer of their relative or friend as possible, and to take that information and your questions to your cancer care provider, because information is power, and together we can go forward to treat your cancer in the best way possible. So on behalf of Icon Group, I thank you to Renee and thank you to Mohammed for giving up their time tonight, and thank you to everyone watching. Hope you have a good evening, and that we hope to see you again, of course, for our next Facebook Live session that hopefully will be coming up in the next number of weeks.
Thank you.
Thanks very much. Thanks for watching us.